Please see the chat for important information regarding CE credit. Just a reminder, attendees, in order to receive your CE certificate, you must complete the post-session evaluation that will be in your CE wallet in your TPN Health account within 24 hours after the session ends. Thanks for joining us for Understanding Higher Levels of Care, presented by Dr. Moshe Winograd. Dr. Moshe Winograd is a licensed psychologist and owner of Rejuvenate Counseling, a group practice specializing in working with families and their loved ones, helping them navigate treatment for substance abuse and serious mental illness. Other areas of specialty include couples counseling and pregnancy-related issues. Dr. Winograd also volunteers for Knafaim, running men's pregnancy law support groups. He lives in Boca Raton, Florida, with his wife and 4 children. My name is Jordan Cooper. I will be your moderator for this session. On behalf of the TPN Health team, I'd like to say a big thank you to Dr. Moshe Winograd, and I'm going to pass things off to Deborah Lawton, who will be saying a few things on behalf of Sandstone Care. And you can go ahead and take things away.
All right, thank you. Yeah, so thanks everyone for joining us today. My name is Deborah Lawton. I'm a therapist and I'm the clinical outreach manager here at Sandstone Care. In case you're not already familiar with Sandstone, we provide a full continuum of care for primary mental health, substance use, and dual diagnosis treatment for teens and young adults, ages 13 through 30. And then we also have a program for detox and residential treatment for adults, ages 18 and up. And that's our program that has no age cap. So we provide the detox and residential levels of care. We've got a teen residential, which is the only substance use residential facility for teens in the Mid-Atlantic. And we also have IOP and PHP with separate tracks for both dual diagnosis or SUD and mental health. We've got locations throughout Maryland, Virginia, Illinois, and Colorado, and we accept clients from all over the US. We are in network with most major insurances, including TRICARE and Kaiser. I'm happy to talk more offline about our services and your needs. I'll put my info in the chat for your reference. And I'm excited to bring you this training today. I hope it's helpful for you in determining when a higher level of care is needed and how to go about that process. So thank you for giving us this training today, Dr. Winograd. It's all yours.
Thank you so much. It's a pleasure to be here with you all. In terms of the format, I will not be sharing my screen at any point. You have access to an outline that I'm going to stick pretty close to, so that should help you with being able to follow along. And it's really, really exciting to be here. I'm loving seeing the chat, seeing people popping up from all across the country, and I think I saw at least one international location. So this is really exciting to be able to be here with you. I commend you. You've taken a very significant step in being able to improve your knowledge base in terms of helping people. And I don't make any assumptions as to who you're helping, so I'm assuming it's pretty broad-based, diverse. You might be working with your patients, with their families, maybe it's in your community, in your organizations. And I hope that the range of what I'm going to cover is going to be helpful for all of that as well. I want to thank TPN for hosting us. And Deborah, thank you to you and everybody at Sandstone for what you do and for hosting this as well. In terms of questions, so I'll keep a loose eye on the chat and or the hands raised. If there's questions that seem broad enough, relevant enough to the group, I might take breaks and tackle them in between things. Otherwise, I'll probably plan at the hour point, so halfway through, to take a few minutes for questions. That gives those of you that need a chance to run to the bathroom, grab a drink, whatever. And then I'll leave time at the end for questions as well. And as well, people can find me offline as well. I'm happy to talk about this stuff. I love talking about this stuff, so we can do that as well. So to start with, I wanted you to consider the following. So typically people come to a higher level of care when some version of outpatient treatment is not working. Sometimes there already is an outpatient program in place, some sort of individual therapy, a series of therapies, psychiatric care, and it's just no longer working, whether that's been tried for a long time, a short time, but it's reached a point where it's not working. Some people enter more quickly on the acute side, so there may have not been an issue previously and something happened rather quickly, seemingly overnight. Sometimes the issue has been going on for a while, but there hasn't actually been outpatient care. But at this point in time, the care need is strong enough that we're actually jumping straight ahead to a higher level of care. And I want you to think about the why. So this idea of why shows up a lot in, I think, like self-help business books in terms of like businesses, know your why, why are you in this? What are you doing? And I think I find myself thinking a lot about this when it comes to treatment as well. And a lot of times, people, when I meet them at the point that they're entering treatment, the goals are fairly basic, fundamentally important and critical, but also fairly basic, which is to say is that people are very often at this point focused on survival. So in a very literal sense, especially, for example, when it comes to substance abuse, people just want to see their loved one live. There's very serious risk issues when it relates to substance abuse. At the point that we meet, very often people have had some pretty close calls and scares in the context of overdosing and being in an ICU, drunk driving and the damage that can cause, other medical issues that come up in the context of substance use. And so people are very often just fearful, terrified, and they'll do or say they will do just about anything to help their loved ones survive. And that's true sometimes in the mental health spectrum as well, meaning people who are often at the residential stage or higher level of care stage have reached such a low point of functioning, and it's been so draining on the family system that we're coming in and the minimal goal, which is often the only focus for a good part of the time, is surviving. And I want to encourage you in this context as a professional to see a bit broader than that. Survival is important. We're not going anywhere without a patient that's alive and hopefully healthy and well. But that should really be just our minimum standard. And we can do a lot more. And not everything's going to happen at a higher level of care. There's a continuum of care, which we'll talk a bit more about today. But higher levels of care are very, very robust programs with a tremendous amount to offer. And it's not just about, can I keep my loved one alive? That's definitely the starting point. That might be a significant motivator to get into treatment. But I want you to think about more. And so as we're talking, I suggest I created a fairly simple, like, guided visualization that maybe can help you get into that space. When I work with a patient, I'm often trying to imagine what real wellness and thriving would look like. And I want to share, it's a bit of a random story, but I was at a professional event and I met somebody there. And she was talking about her daughter and how proud she is of her. And I think her daughter was in her 20s and she played golf. I know nothing about golf, so I might not be understanding what I'm saying, but I think the message still comes across. She was sharing that her daughter was at a very significant golf tournament. And at one point, she was supposed to mark her ball, I guess the position where it lands in before you move on to the next stage. And she didn't do it, but it wasn't noticed. And she moved forward into the tournament, not having realized she had not done this. And she was on track to do very well. And she then realized she had not done this. And despite it not having been noticed by whatever officials are in charge of this tournament, she decided to disqualify herself on her own. And for her, that's something that she felt that was the only way she wanted to win this tournament, the right way. The game has rules, and the game only makes sense and has meaning in the context of those rules. And that was what she did. And it was a significant setback in terms of where she was in that tournament, but that was right for her. And so my colleague was sharing this in the context of how proud she was of her daughter, that although golf has been so important, and my colleague was saying how much time she tries to work out her schedule to be able to go with her daughter to her tournaments, but this just didn't sit right with her that she would do it any other way. And so I think that's an interesting, random, almost simple day-to-day kind of example of what thriving might look like for somebody, that they're in their element, they have this passion in terms of a sport that they're playing, and they're healthy enough and well enough that their values and their integrity shines forward, that even at a significant cost, that's what they want to do. And that stood out as a model moment for my colleague, that in thinking about her daughter, her success was as much the actual tournaments that she was winning, but the way that she was able to be a healthy, happy, functioning human with values. And I encourage you that in terms of the visualization, so I tried to think about what this person was like starting fresh. So we're often encountering people literally on their worst possible day. I always try to remember that. People call in all sorts of states of distress, and they're sometimes not always so pleasant to deal with. And I always try to remember that I'm meeting them on their worst day. And hopefully they've had better days and will have better days. But for the moment, this is how we're getting them. And so I encourage you, when you encounter a patient, when you think about the patients, the families you're working with, try to imagine what they were like fresh. And I encourage you to encourage them to do that as well. So that when the parents come to you and are talking about care for their loved one, go back in time. So if it's a child, go back to that moment of birth, that beautiful moment. Think about that scene. I think a lot of it's pretty standardized at this point, that, white, blue, pink hospital blanket and hat, totally fresh, and whatever dreams you as a parent might have had. If it's a spouse, what it was like when you first met and fell in love with each other, and all the dreams, hopes, and aspirations that you had. And I think that, imagining that even just briefly amidst the chaos of getting a family organized around treatment needs, I think is really helpful in terms of holding in mind this idea that treatment is not just about survival. It's an important part, it's a necessary part, it's critical. And at the very least, hopefully they will come out of treatment having gotten that. But there's so many more things that treatment can do. It is one of the most powerful ways of getting help. And that's something that I think that we're not yet fully accessing enough. I think too often we get linked and limited by the chaos going on. And we default to the lowest, piece, which is the survival piece. So I encourage you to try to do that. Another element that I want to talk about is that very often people talk about getting back to something. Something was good, and we're trying to get back to that. Like, that's my goal for treatment. And I think that that's often relevant, meaning often enough people have had a great life. Something then came up, and we're trying to get back to that life. A lot of times, though, if you take a good history and listen closely to what's going on, it's been a long time since anything was good, and there's been a lot of dysfunction. And the mindset of going back to something may not be the healthiest. And sometimes we're trying to change the narrative to, what are we trying to build? We're building something new. I remember once coming across this concept in terms of like my couples therapy training, that a couple walks in and they talk about wanting to fix the marriage, improve the marriage, etc. And they were talking about the perspective needing to be, we're actually here to kill this marriage, meaning this version of marriage that you've had is no longer working. We're not looking to fix it. It has to die. And we're actually looking, and we're going to create the opportunity for there to be a new marriage, a new relationship is possible. And that's what you're going to work to build. It doesn't mean you're cutting out the people, meaning it could be that you're keeping your spouse. In terms of the family work, it could be that you are going back to your spouse, your parents, your kids. We're not looking at necessarily cutting people out, but we are looking at recreating anew. And I find that too often people see that like playing board is fixed and limited by what's already there, and missing the opportunity that you can substantially change things by trying to really create something new. And so what I want to do with you is really help you understand, we'll call it the landscape of higher levels of care. It is not a one thing, and it is far from standardized relative to other things in life that we're used to being a bit more standardized. That being said, we're going to try to create a framework that it'll become fairly standardized in your mind. And as you think through what your patient's needs are, you'll have a pretty good ability to analyze and evaluate options across different settings, even as they're sometimes using different terms and talking about it in a way that feels different, but you'll know enough at this point that you can then figure out, oh, so I'm looking at programs A and B, and they seem to be using different terms, but I now know enough to figure out how to compare this part and that part of two different programs. But it requires a sophistication. Now, I don't know what groups or listservs or organizations that you're part of, but I think this is becoming, I don't know if it's more common, but I'm starting to see it more in a way that is concerning to me. The people who are asking requests for referrals of all types, although I'll focus more on treatment center types, the requests tend to be fairly simplistic and hardly seem to do justice to what's really being asked. Now, I think in terms of treatment centers, I think people are often stuck in terms of they're not really sure what to ask. And I think when you walk away from today, you'll have a much better sense of it. But I see, people ask requests, and I'll just share some examples. I polled, completely anonymous, de-identified from groups that I'm on. So one person asked it, I'm looking for a referral for an outpatient drug rehab place in the Miami area that is doing in-person group and therapy, has insurance. That was the entirety of the request. So in concept, that could lead to a robust back and forth conversation where people are asking about a lot more questions about what you're looking for. But that doesn't typically happen. In my experience, the only response that people get when they post this is names of places. Now, these could be good or less good names, and we'll talk more about my thoughts about what it means to be a good or not good treatment center. But in general, I don't know that you know enough at this point to be suggesting names of any sorts. Just because you heard the word outpatient drug rehab and you know of 2 places in that geographic area, you don't know anything else about this case at this point. And I think that it's really important to try to figure out a lot more of these things. And my hope is that, by learning more about this stuff today, you'll be in a position where you're able to understand more about what you do want to be asking for. I'll give you another example. This one's, I have a patient on Medicaid who requires a long-term residential hospitalization to address long-standing trauma and PTSD. Anyone know of good places anywhere in the United States or in Canada? So again, this is fairly broad and generic. Again, we're hearing something about a specific insurance that the treatment center takes. They're talking about a long-term stay. I don't really know what long-term means. If you look across treatment programs, there's very different ideas as to what shorter versus longer term is. They're talking about long-standing trauma and PTSD. Last I checked, PTSD was a traumatic stress disorder. So I'm not sure what long-standing trauma adds information-wise in addition to the PTSD. And again, that buzzword, anyone know of good places? We might all have very different ideas of good places. In fact, although I'll give you my way of thinking about it, I think it's very fair and plausible that every one of you on this call today might walk away with very different ideas as to what's good in terms of the way you think about your work. And that's fair. So I think it's a fairly simplistic way of saying, do you know of a good place? I understand intuitively, we all understand that when somebody says good, we have some sense as to what they might want. But I always also found it a funny thing, meaning when I look at a list of questions, I don't sit there and say, let's see, I know good therapists and bad therapists. I'm going to give you the bad therapist option today. Like, it feels almost silly. I would never think to give somebody an option that I didn't think was good. So I think it's just important to get beyond like superficial buzzwords and to clarify, like, what do I mean by a good therapist? And again, we might have very different ideas about that. The last one that I'll share as an example, it's a bit more specific. So in that sense, it's more helpful. And it's a good chance to see how you could get a bit more detailed. And again, these are listservs. People know each other better, less better. We're trying to maintain confidentiality. So I understand that there's limits to what we're going to share on a listserv. But this is an example of one that maybe I think gets a little bit closer. So I'm seeking referrals for an inpatient center for an early 30s female that focuses on PTSD, depression, and works with severe PMDD. Ideally, more of a holistic approach with a mind-body spiritual focus. The client would prefer a treatment center on the East Coast, but is open to travel for the right care and can pay out of pocket if needed. So that actually gives you a lot of information to work with. And even if you didn't know that much more, I'd say that you're probably going to do a better job if all you wanted to do is respond to the person with names. Again, you have a little bit of a better sense diagnostically. We're starting to get a picture that is, diagnostically speaking, a bit more complex in terms of the comorbidities, and you want to start thinking about, can the places you have in mind treat the multiple different things that we're hearing about? You're hearing about the gender, the age, which is relevant. If you noticed in Deborah's introduction, she referenced ages for different treatment programs that they have. And treatment centers of all types have different parameters around ages. And then we're hearing about a holistic approach, which I like that they're defining for you. mean, that's a buzzword these days, and it doesn't mean any one thing. Mind, body, spiritual focus is not super specific either, but it does give you a bit more of a direction. So we're in a busy day and age, and probably most people don't sit there and see this pop up in a listserv and say, I'm going to call a complete stranger across the country and volunteer 30 minutes of my time to talk this through. And so we are in a time period where we're probably just giving a name. But I think a question like this gives you a whole lot more that we now better understand to work with. So those are just, 3 different ways that you might see people popping up on a list of asking these questions, or the way you might be asking the questions. And I'm encouraging you to keep that in mind in your background as you think about what we're talking about. So you have the outline in front of you, and we're going to, like I said, stick pretty closely to the format, although I'll be explaining a lot more about it. So we're starting off with overview to levels of care. So really to understand how to make a referral or where are you making a referral to, it's really pretty important that we figure out what are the levels of care. Where are we even referring to? So a couple of caveats. I'm not in this forum endorsing any specific program. That's not my job here. I do make passing reference at times to programs, but that's just to illustrate maybe a very specific point. I'm not endorsing or saying anything positive or negative about any specific program in this context. I'm here to help you understand just the system and how it works and how to best work with it. And in terms of programs, there are some programs that are bad by anybody's definition of bad. Those are the programs you might hear about in the news that get shut down for something. Sometimes it's fraud, whether it's insurance fraud. Sometimes there's some other scandal. That's not to say that a program has to get shut down for every scandal, although we are in a day and age where that might be the more likely outcome in certain cases. So I'm going to assume we're not talking about referring to bad programs. And I mean that fairly objectively. Like whatever we can probably all agree on is a bad program, probably shouldn't be around. Many programs are average, and I'll define what I mean by that. Average does not mean bad per se. And some programs are excellent programs. What makes it right for you is really the fit. And I cannot stress that enough. And I'm going to try to help you understand that more, which is to say is that a program that's average by X, Y, and Z criteria might still be the best program for you at this point in time. And that ties into a lot of factors. We'll go through that. But that really might be the case. And that's not true in other areas of life or industries. And so although we might talk about fit, for example, when it comes to like choosing a college for your 18-year-old child, we do have this idea that there are the best ones and better ones, and there's ranking systems, right? So the Ivy Leagues are a standard that many parts of society will say that that's the best. And there's reasons why that people will say that that's the best. So that's something that there's still relevance to saying, does your child fit this Ivy League versus maybe some other one, or maybe some other program altogether? But there's a standard and a way in which we talk about it being the best and the top. I'm not sure that makes a lot of sense when we talk about treatment centers. I think that treatment is something that's far more individualized than, let's say, a curriculum at a school, which is fairly standardized. There may be room for electives and majors, but the process of college and schooling is still fairly standardized. And so we can create benchmarks and barometers for somewhat objective ranking systems. I don't know that that's as true for treatment centers. I think that becomes true at the minimum side of treatment centers. And so treatment centers go through a licensure process. It might vary by the state in terms of what it's called, but there's some sort of credentialing and licensing that treatment centers typically have. In my experience, not that I've had a lot of work on the admin side, but my sense is that those things are about a certain minimal standard. Often it's about safety, right? So what might be a staffing ratio? What are the protocols for a suicidal patient? Those things are often about the minimum standard, meaning what does it take to open and operate and function such a complex program? It's not necessarily about which treatment modality do you use and how do you use that treatment modality. So it's very important that we have these kinds of standards, but I think they create a minimum, they create the floor, and then there is a lot of room for variation and diversity across different programs. It could be regulated or certified in other ways, but I don't think that's about the basic licensure per se. And so I think that we really just want to focus on what's right for my patient. How do we really make it fit? And we're going to go through a lot of different ideas as to how to do that. So, like I mentioned, there's a lot of different terms across the programs. I'm going to try to use the ones that are most common, and you're going to come out knowing enough that you're going to be able to realize that if a program uses a term that you don't recognize, that that's something that you can still make sense of. I do want to note something about cost. Many people don't access or even think of accessing higher levels of care because of cost. People get these ideas from a lot of different places as to the cost of treatment centers and whether they can or they can't afford it, or even if they technically have the money, whether that's something they should be spending it on. But I think, you know, the actual reality, I think, is a bit more nuanced than people necessarily realize. Treatment centers can be expensive. Now, again, there is a split between, we'll call it, programs that take insurance, in-network even, versus programs that maybe take insurance out of network, programs that don't deal with any of that at all. In my experience, I'd say the average sticker price for a program at the residential level, which we'll define more, is about $1,000 to $2,000 a day. It's a lot of money, and programs range between, typically, I'd say 30 to 90 days. That's a big cost, and that's just the residential side. And so a lot of people hear these numbers and they don't think that that's relevant to them at all. But I think that it is worth, even if you're working with somebody that seemingly can't afford it, to maybe dig a bit deeper. Like I said, there is insurance. And my sense is that more and more we're starting to see programs take insurance in ways that we haven't seen in the past. Whether it's going in network with insurance companies, or whether it's creating what we call a single case agreement. So they don't take the insurance, but they work out an arrangement with insurance for this one specific patient. Or that they're doing more to facilitate out-of-network billing. So, for example, in private practice, like in my own practice, I don't engage that much with the billing of out-of-network claims. I provide patients with what we call a super bill for them to submit it on their own. I'll do my best to troubleshoot with them if they're getting any response other than here's a check in the mail, but I'm not interfacing with the insurance company directly. It's much more common in treatment centers, even if they don't take insurance and network, that they will have a whole team, often called a UR team, utilization review. They'll have a whole team that will work on your behalf to go and submit claims and fight for them. Very often there's a very lengthy appeals process to make that happen. And they're good at this. They have a lot of experience with this. They work with these insurance companies every day. And they're often pretty successful at getting coverage in a way that, left to your own devices, just submitting out-of-network receipts is not going to get you that far. Aside from insurance, I do also want to suggest that for some people, it would be appropriate to borrow money. We borrow money for all sorts of things. We borrow money to buy cars, to buy jewelry, to buy houses. And we can and should consider that at times it might be important to borrow money for our loved ones' healthcare. I think the same way you would borrow any money, you should be mindful as to how you do it and whether that's realistic for you. But that is an option, and there's different formats of borrowing money. There's trying to get a formal loan, there's trying to create payment plans, there's borrowing money from friends and family. But I think that's worth considering at certain points. And what I'm seeing more recently is just the popularity of what we'll call crowdsourcing, crowdfunding platforms for every cause under the sun. And I'm seeing people do this for treatment as well. And I think that's an option as well. There are people that want to give money to the right causes, and sometimes it's your patient. Again, depending on your role with them, you may or may not be involved directly in the fundraising, but it's worth considering that the people that don't seem like they have the money might have it. And then there's broader options. Many people come from communities, and many communities have funding of different sorts. It might be a private foundation, it might be a religious institution, but it might be even a job. Some jobs might have funds that they're willing to tap into for these kinds of things. And so I think that it is worth, thinking beyond just, do I think this person actually has X amount of money in their bank account? And I would remind you that we should see these as investments. We're not just putting money into a sinking ship. If you're going about it the right way, this is an investment. In the same way you might spend a lot of money on people, like I said, to get a college education, and that's an investment in somebody's future. This too, if done the right way, is an investment in people's future. All that being said, I still readily recognize that costs are a significant barrier for many people. And we do need to see more systemic change, whether it's on the insurance side, whether it's on the government side. But there's definitely a lot of room for a systemic change in terms of this. And one simple point just for you to realize is that I would encourage you, if you don't yet have that much experience with the way insurance works with this stuff, is that in my experience, and I've made up these categories on my own, but I think there's two types of ways insurance pushes back. One is a denial of coverage, and the other one is what I would just call a bureaucratic nightmare. Um, People typically assume that when insurance responds with anything other than a check, that they're denying coverage. In my experience, certainly on the outpatient basis, that's not necessarily true. Remember, the difference as to what insurance is being asked to pay outpatient versus inpatient is vastly different. One is significantly higher, and they're going to create more obstacles when it comes to the more they have to pay. But in terms of the denials, so if it's a denial of coverage, what they're essentially saying is you presented patient X, you said that they have this or that issue and they need this or that type of care. Well, we disagree. You either don't have that issue going on or that issue is going on, but we think it can be treated in another way, i.e., a cheaper way. That's a denial of coverage. That's getting into the technicalities of the case itself. So when you're working in a treatment center and you're the utilization review team trying to create an appeal, what you're coming to the insurance is you're trying to say, well, let me help you understand why this issue is as serious as it is and why this treatment is needed that we only offer at a higher level of care. Again, these all happen in very technical, clinical, and or insurance type terms, but that's essentially the conversation that you're trying to have with the insurance company. When it comes to the bureaucratic side, very often what people read, and most of what insurance sends you back is barely intelligible, but what people read is they read it as a denial, but it's really another way I would phrase it is it's we're having trouble processing your request. They're not actually denying it. What they're saying is there's something that you submitted that we can't process. In my experience, the most common way they do that at the outpatient level is around my NPI number. So every provider has an NPI number, and that has to make it onto your super bill that you're submitting to insurance. And so they come back and they say some version of we can't process your NPI number. To me, that's one of the silliest sounding statements I've ever heard for the following reason. Well, if any of you put my name and NPI number into Google right now, you will find my NPI number in 2 seconds. It's the same number I've always had. It's never changed. I assume it never will. It's the same number I put on every single super bill. It's just automatically put onto every single super bill my EHR generates. It's the same number that the insurance used on my last patient that went through this insurance to get it covered. So what does that mean you can't process my NPI number? If you, the insurance, Googled me, you would find this information too. And most of the time, when all we do is we simply resubmit the same piece of paper that we sent them the first time, somehow it gets processed the second time. And so to me, that's a bureaucratic nightmare that they create. And it works for them because X% of people will drop out of that process every time they get some letter like that. They will simply say, I don't know how to do this. This seems too complicated. Or insurance looks like they're denying my claim. And so I guess it just is what it is. Some people fight, but a certain percent will drop out at every stage. And that's a win for the insurance company in terms of not paying out more money. But they didn't actually deny a claim. So meaning if you tried to fight them, let's say you wanted to go full throttle and get a lawyer and sue them for breach of contract, there kind of is no breach of contract because they didn't actually deny you. They just gave you this, we're sorry, we can't process it. Please help us out. It all sounds nice and well, but it's really a game as far as I'm concerned, because insurance can figure this out for themselves. So I would encourage you just to keep in mind that in the world of insurance, that may or may not seem that doable. It is difficult, but it is potentially doable. And to, again, not rule out the possibility for a higher level of care just because the cost or insurance doesn't immediately seem to be relevant. We're going to also talk about the staffing at a treatment center. So if you've not yet really been exposed to treatment centers and any higher level of care, at an outpatient basis, you're familiar with the idea that a patient has a therapist and or a psychiatrist. And that's pretty much it, right? Somebody's doing talk therapy of some sorts or another. Somebody's prescribing medication. And that's mostly the extent that we're going to see at an outpatient basis. There's a lot of random things you might see pop up at times, but on average, on an outpatient basis, that's what you're going to see. When you get to a treatment center, so if you go onto a treatment center's websites, most websites are formatted pretty similar. So there's some sort of about section, and then there's a subsection called Meet the Team. And you'll be able to see that there is a whole range of staff that you've never even heard of. You'll find your therapist probably, you'll find your psychiatrist, but then there's a whole bunch of other staff that you might never have heard of or seen before. And that's really an important piece. And that's what makes treatment centers so robust in terms of what they offer and why they can do so much more than the patient being at an outpatient basis. So you'll have your therapists, and you'll have all types of therapists, across different modalities, across different degree types, providing different things. You'll have your psychiatry team, but typically you'll also find something along the lines of medical. Usually that's represented by nursing, even though there often is a doctor or some other provider above nursing. But there's a focus on the nursing staff. In part, if you think about it, especially at residential, if treatment's 24/7, well, the nursing staff is there sometimes even 24/7. The doctor's almost never going to be there 24/7. So the nursing staff is a big part of the milieu in that they're there both in terms of medication, in terms of monitoring different things. So you'll see nursing staff. You'll also see all sorts of supplementary clinical staff. Meaning when I say supplementary, in the sense that if you're a mental health therapist and your mind is wrapped around my patient has OCD, they're working with an ERP specialist, you'll also start seeing other specialties pop up as well outside of mental health. It could be anything from PT to OT. It could be nutritionists. It could be the yoga instructors. Then there's the whole world of, we'll call it the residential staff. So where I used to work, we called them the tech staff. I think the full name is probably behavioral tech staff. Treatment centers use a variety of terms for these people, but they're really the ones that keep the place running 24/7. In my experience, by the way, they're gold. I think treatment centers can't run without them. Like, I could be the best therapist in the world, and I certainly thought I was a great therapist, but I mean, without them, we're useless. You're talking about keeping very sick people contained together with other very sick people over many days in it could be a tight space, it could be a big space, and you're talking about them working well together, and 24/7. That is not an easy thing to do. As a therapist, I have the luxury of going home at 5 o'clock, and I trust that the tech staff are going to do a great job keeping these patients contained and safe. If I wanted to have my patients doing things after hours, that they're going to follow through on that they know how to handle crisis, both in terms of what they're trained to do, what they're trained to or expected to bump up the ladder and activate maybe the therapist on call. But that is something that I think people really don't appreciate necessarily when walking into treatment. Very often our focus in looking into the place is, oh, tell me about the therapist. What type of degree do they have? What modality do they use? Tell me about the psychiatrist. What board certification do they have? Those are all great questions, but it's just as important to understand the quality of the tech staff. And it's not as easy, I think, for a treatment center to market, right? Many of them are high school dropouts. Many of them are in recovery themselves. But these are solid people that are really doing incredible work keeping treatment going. And it's worth getting to know about that too. So when you come into the world of higher levels of care, again, you're going to encounter a lot of different types of providers that you might not have as much experience with. And it's important to keep in mind that many of them are in the, so to say, different disciplines. It's hard across disciplines to communicate effectively, even within disciplines in a sense. Like, I'm a psychologist on this conference today. I assume we have some psychologists, some social workers, some mental health counselors, some marriage and family therapists. Maybe there's something else that I missed. And even within, sometimes it's hard to talk to each other. We get very hung up on some of our differences. I'm CBT, you're psychodynamic, you're EMDR. We don't, it's hard sometimes to talk across these things, let alone across other disciplines. But that's really important to do when you're now entering a setting where you have all that stuff going on. In addition, I'm going to continue to be describing an ideal set of circumstances. I'm going to give you what I'll consider to be the gold standard. And I want you to realize that I don't think there's a program out there that necessarily has all of them. And I think very few have most of them. And that's fine. These are very complex systems. I think it's probably impossible to create all of them in one place. What I'm trying to do is empower you to kind of get a sense as to what's important and how important it is, and to understand how to weigh these factors against what exists and what's realistic for you so that you can then make the best informed decision. So let's get into the nuts and bolts of what the programs are. I'm choosing to start bottom up, meaning the lowest level of care, and we'll work our way up. That's my choice. You could theoretically start it the other way around. So the lowest level, meaning once you move on from a outpatient therapist and psychiatrist, is an IOP. IOP stands for Intensive Outpatient. Now, IOP, in terms of the term, I think is actually probably the least standardized of the three terms I'll be discussing, in part because IOP, you're at a stage where it's still fairly fluid as to what people need, I think, and different places choose to run them in different ways. So one of the biggest differences you'll see is if I enter an IOP, how often am I supposed to go? So some places run an IOP 2 or 3 days a week, and some places run it 5 days a week. Some places run it in the morning or afternoon or an evening. There's a lot of different ways people have structured IOPs. I think the most common similarity is that they're about 10 to 15 clinical hours a week at the minimum. And then, like I said, there are places that might do it for longer. But they're about 10 to 15 hours at the minimum. So you're now looking at people having a individual therapist, probably one session a week in most places. And then the rest of it's going to be primarily group therapy-based work. And then depending on the IOP, you might have other things thrown in as well. So psychiatry actually, for example, is not standard across IOPs in the way it would be at a residential treatment center. I don't think you'll really find a residential treatment center without psychiatry. There are some residential programs that are maybe straight substance abuse that don't have an in-house psychiatrist, but they'll be very familiar with the idea that you want a psychiatrist, and they'll likely have an arrangement with an outpatient psychiatrist that consults into their setting. At the IOP level, though, you very regularly will find programs that do not have a psychiatrist. Part of that is because IOP, and again, it depends sort of which direction you're coming from, whether you're coming from a residential program, moving your way down the level of care, or you're coming from outpatient and moving up. But if you're an outpatient patient and your therapist says, okay, it's time to do IOP, and you say, okay, sure, if you've already had a psychiatrist, it may not make sense that you want to switch psychiatrists. You have your psychiatrist, they know you, they can continue to prescribe to you. You're not necessarily looking for a new psychiatrist. So there are these variations across IOPs, just given some of these differences. So again, minimum is basically 10 to 15 hours a week. You're going to have an individual therapy. You're going to have multiple group therapies. Different programs have different ways that they add other things in, whether it's nutrition or art therapy. And then, like I said, they may or may not have psychiatry. In terms of PHP, so PHP stands for Partial Hospitalization Program. It doesn't technically speaking have anything to do with a hospital. Although it's confusing because there are hospitals out there that do have programs, including PHP programs. But in and of itself, it just means that it's somewhere in between IOP and residential. Typically, the setup in a PHP is we'll call it 9 to 5, Monday through Friday. So think of it as a full-time job. We're now going to treatment full-time. We're probably going 5 days a week, and it's probably most, if not the full day. What differentiates it from residential is that it's not 24/7. And so you're not going to be there probably after 5 o'clock, and you are not living there. Now, it really depends at this point because there are plenty of people that still don't live at home during PHP, and for that matter, even during IOP. But the housing component at this point is probably not directly connected to the program itself. Even if the program runs a housing, geographically, it's often a little bit removed from where the clinical is. Not far, it could be a mile down the road, but that's not the same as maybe being on a treatment center's campus where everything is really mixed in together. And so PHP, again, you could be doing it from the outside, working your way up the levels of care, or it could be your step down from residential. And these are very, very different setups. And I think it really is important to think about that. So we discussed this just way at the beginning as to how people get into treatment, but there are people that they're coming straight from the outpatient basis and things aren't working out. And they are now ready to move up a level of care, but things are stable enough that we're okay doing a lower level of care first. And so they might be going from IOP to PHP to residential if it's continuing to not work out. The alternate is that there are people that are just so sick at this point that we must put them right into a highest level of care. Sometimes they start at residential. Sometimes they're actually starting at an inpatient hospital psych unit and then being discharged from there to residential. I think it's important as you think about your patient and the programs that are out there that you want to think about which, so to say, direction your patient's going in, right? Is it going from outside up? Is it going from the top down? And you want to think about how the programs seem to be designed. So in my experience, I've seen the following difference. When programs run the full continuum of care, so let's say a program has a residential program, a PHP program, and an IOP program. So you'll see variation. Sometimes those are all on the same campus, they share therapists, they share space. Sometimes it's fairly separate, like it's a separate campus, sometimes really close but separate, sometimes not so close and separate. So in my experience, sometimes the programs that have, let's say, all three, they have the full continuum of care. I don't think there's enough differentiation for some patients at, for example, the IOP level, meaning the program at its core is a residential program. The design is built around residential. And the next step down programs are essentially that program in a lighter and lighter version. And that works for some people, but I don't know that it works for everybody because it ends up leading, I think, to too much of a cookie cutter approach to the patients that are there, which at the residential level makes more sense to me. People are acute enough to the point that I think their stabilization needs are often fairly similar. And so it makes sense that we're going to put 30, 40 people with differing diagnoses and issues and contextual factors in a fairly similar environment. I think that makes less sense at the IOP level where people are healthier and we're closer to connecting them to their life goals, that you're looking at something very different. So I'll give you an example that I see that comes up a lot at the IOP level. And that's in terms of what are our patients doing next? So you're in IOP, maybe you've been in treatment in residential, PHP, you're now in IOP, you're now your 5th month or 6th month into treatment, and what's happening next? So there are a few different options. So I'll stick with adults for now, for the example, not adolescents, but let's say you're 20 years old. So are we looking at you going to work, or are we looking at you going to college? Or maybe you can't do either, and at best, we're looking at you volunteering once or twice a week. Those are very different patients and profiles at that point. I've had patients in treatment with me that were on medical leave from an Ivy League school. Like they're looking to get back to their Ivy League school and finish their degree at one of the top campuses in the country. That is very different than the patient that barely made it through high school and is so cognitively not intact at this point due to their psychosis that at best we're looking at them volunteering at maybe like a Habitat for Humanity thrift shop. But they end up getting lumped into the same vocational skills group. And that frustrates them. And it frustrates everybody because you're working with two very different people that don't really belong in this group at this point. And so I think that's something that I see it more when the program's designed as like a step down from the higher level of care from the residential, that it ends up being like a lighter extension of what they were offering originally. And there's not as much thought or time or resources put into how are we really developing this as a standalone program and for people that have much more individualized needs. Now that's a trend I've seen. I wouldn't say that that's true everywhere, and it just warrants you looking more closely into it. And again, thinking about where you're putting your patient relative to where they're coming from and relative to what the goals are. I would also encourage you to consider, as we try to map this all out, it really is important to try to be able to think about all of this in the beginning, meaning I'm telling you about a process that can span a year, maybe even more. If you think about inpatient and residential and PHP and IOP and outpatient and sober livings, transitional housings, and a bunch of other things, that could be maybe even a year. I'd like you to be able to get to the point that you could think about, and on day one, what kind of IOP you might need. Now, I wouldn't tell you to choose the IOP on day one. You're still 6 months away and a lot's going to change, but you should have a sense as to where you're headed because it does change certain things even at day one. One other thing I'm seeing is, and I think this was largely a COVID phenomenon that has continued, is a proliferation of virtual IOPs. COVID created a problem for programs in terms of how do we navigate this, like it created a problem for everybody. So residential was not so hard in this sense. You could quarantine a patient and then get them into your residential program and then create a system where you can hopefully keep them all safe, whatever that system was about. But IOP became more complicated because IOP was done where patients come and go every single day. So how are we really doing that? And so a lot of programs created and I think also another part of it was that people who needed a higher level of care, some people weren't happy with the way residential programs ran their COVID protocols. And so they wanted something more, but weren't willing to leave their house to go to a program. Or people were struggling more and outpatient therapy wasn't enough, but these were not your typical patients in terms of they needed a residential program. So I think between all of that, virtual programs popped up overnight. And I think they're limited in terms of what they can do. For some patients, it's perfect. It increases access to care. It allows them to continue working, being at home with their kids, whatever that's about. And I don't have an issue with the concept. I just think it's important to really understand what the program is, what it's not, and where your patient is and how appropriate that is for your patient. In general, I think for higher level of care kinds of patients, the virtual option is not always the right option. Some of them really struggle to be present with you when you're on a screen with them. And I think you have to think through whether or not that's appropriate for this patient. So it's amazing that these things have opened and have increased access, but you want to think about how it works for your patient. I want to touch upon housing for a moment. So when you're in residential, housing is for all practical purposes included, right? Care is 24/7. Different programs have different physical layouts to how they do it. Some programs have a large, massive suburban campus, everything with, streams and horses on there. And some programs are, relatively speaking, tiny. It's a building or two. It looks like an inner city dorm. There really ranges what housing looks like. And also, not all programs keep housing on the same campus as clinical. Some programs split that off a bit. There's a short drive. They have vans that drive you back and forth. There's different layouts for that, but it's included. So when you think about if treatment costs $1,000 a day, that's typically going to include housing. And if it is covered by insurance, that's going to include the housing as well. When you get to PHP and IOP, for the most part, housing is not included, even if the program runs a housing unit. Certainly not at the insurance level. Insurance, while they recognize housing as part of what they have to pay for in terms of residential care, the same way when you're in a hospital, they pay for your bed essentially. When it comes to PHP and IOP, we have not yet created a system, at least not across the board that I'm aware of, that insurance recognizes housing as part of the treatment that they need to pay for. And so although many programs, certainly at the PHP level, will operate their own housing and strongly, strongly urge you that this patient belongs in their clinical program and their housing, you still have to pay for that on your own. And it's not even going to be reimbursed out of network by insurance because they're not recognizing that as part of the care, even though you and I have decided it's part of this patient's care. The costs really vary. I mean, there are some cheaper options. Typically, those might be like a standalone, very, very basic sober living. I've seen some, let's say like in South Florida where I am, they could be $200-300 a week. That's not a crazy cost. It adds up relative to everything else, but that's on the lower end. And then I've seen places that are charging $5,000 to $8,000, $10,000 a month for the housing. That's a very big difference. And again, that's not something that's going to end up being typically reimbursed by insurance. So that's something to keep in mind as well, that many of the patients at PHP and maybe even IOP will need housing. Housing meaning not just rent an apartment, but some sort of supportive housing. And typically, even if the program's the one running it, it's not under insurance in the way that the clinical services might be. I also want to mention briefly, it's not something I have a lot of direct experience with, but just at a high level, which I'll call specialized programs. Primarily experiential or wilderness programs. They tend to be more popular, I think, in the adolescent segment of treatment, more so than adults. I think very recently there's been some issues, I think, in terms of safety, and some of these programs have actually shut down. So I think it might be becoming less of a popular option in some settings. But they still exist. And they're still, like I said, they've been a very popular option for adolescents in particular. They offer certain unique opportunities that you can't do in a traditional treatment center setting. There are pros and cons. So I think in terms of the pros, they often offer a out-of-the-box approach relative to a more standardized approach that I think you'll see in a quote-unquote regular program. We mentioned somebody was looking for a holistic referral before. I think these experiential programs often fit the bill for holistic a little bit more for some people that are looking for that type. They're all set in nature in some capacity or another. Utah has a lot of these programs I've seen. Utah's a beautiful state. There's a lot of really nice outdoor stuff there. A lot of them try to leverage the idea of team building as a community, not just in like we're managing ourselves in terms of, I don't steal from your fridge and you don't steal from my fridge, but really team building in terms of being out, you're doing activities together, whether it's pitching a tent, lighting a campfire, whatever, that you can't really do on your own. And it's less confined than a residential space. Like I said, there's variation across residential spaces, but some of them are pretty tight. If you're going to be living there for 30, 60 days with a lot of other people with pretty serious issues, and these could be a little bit less confined. Some of the cons in terms of a program like this, there are safety issues. There are patients that need a lot of tight supervision in a way that's not realistic to provide at an outpatient basis. Sorry, at a outdoor setting. There's also less access to certain supports. A lot of these places are in a pretty remote setting. Maybe they'll bring a satellite phone for emergencies, but this is not like, oh, the patient's acting a bit funny, let's have the psychiatrist pop in for 5 minutes to see them. So it really is more limited in terms of that. So there's like a paradox where on one hand, you're sending very sick people to these programs, but they need to be not too sick that we can't effectively monitor and support them. One other option out there, I wouldn't see it as like a substitute for a true higher level of care need, but it's in this category that I think is worth knowing about is intensives. Intensives, I think, are becoming more popular for different reasons. I'll give you the most standard version. It's like a week-long intensive. They typically have different tracks. So like trauma is a very popular intensive track. Relationships, either as a couple or as an individual, is a very popular format. Typically, you go somewhere for a week. They try to make this setting very nice. It might be a little bit nicer resort-like than maybe your average treatment center is. It's going to probably offer more than just talk therapy. There's a lot of group therapies that are different and more experiential. Definitely, they've got more of that holistic vibe often going on. Sometimes intensives are a specific modality type. I don't truly think it's a substitute when people genuinely need a real higher level of care. That being said, a lot of the people that you're working with will not either ever or at this point sign up for a 2-3 month program. And getting them to go somewhere for a week is the best option. And that could be the starting point. I do think it's important to be cautious because the intensives that are out there, many of them are very good at what they do. And they crack you open like an egg. And I've seen too many people come out of them raw, kind of, we'll call it emotionally bleeding. And there's no real follow-up plan. And that I don't think is particularly helpful for the patients as well. And so I think that it's really important that if you're considering an intensive, that you really think about it as one step in a process, that the patient does still have to go through other things. It may get you out of the need for a higher level of care sometimes, but they're going to need some sort of follow-up after that. And you should have thought about that and discussed that, not just say, here's this amazing intensive, they've got a cool promo video, go there for a week and you're back and you're fixed. And then lastly, again, this is not so much our space, but there is this whole world of inpatient psych units that kind of exists, I'd say, adjacent to treatment centers. I say adjacent because in some ways an inpatient psych unit overlaps with a residential treatment center, but in some really important ways it's different. There is also a lot of variability in hospitals. And I would say that there are both general psych units, and then there are some hospitals with very specialized units. So I can think of like McLean in Boston. I'm from New York, so like the New York Presbyterian system there is a behemoth. And they'll have tracks. You could be in an inpatient unit for OCD. They'll have an early first episode psychosis track, an eating disorder track. Relative to South Florida, where I live now, there's no such thing. There's just a general psych unit. And for all practical purposes, I just call it's glorified babysitting, meaning it's the safest legal way we can keep you alive for the minimum amount of time before you just essentially discharge you to the street. There's not a lot of care going on in these places relative to these other places. Again, it's safety, it's stabilization. We can do a little bit of med work, but it's often pretty shoddy, despite, I think, people's best efforts. But you're getting a very limited history in an emergency hospital setting. You typically, for various reasons, have little access to whatever happened outside before or after. So I wouldn't necessarily see the hospital as a place that we'd refer to for a higher level of care. Short of an emergency, if you are in a setting, like let's say you live in New York City, then yeah, some of these hospitals do have options that maybe could be a substitute for residential. It depends on a lot of factors. And keep in mind that not every time we talk about a hospital program does it automatically take insurance. So Sometimes the hospital program takes insurance in a way that a program doesn't, and therefore that's worthy of considering it. But sometimes they charge and maybe even charge more than the programs you're familiar with. Last I checked, for example, one of the programs at McLean was $70,000 for maybe 2 months. That's hefty. That's not necessarily cheaper than a treatment center. So we're going to pause here. That's essentially the first half of what we're doing. The second half, I'm going to walk you through a model that I created for thinking through, now that you know all the background content, for how to actually go ahead and make that referral, like what are the things you need to think about. So I think we'll pause for about 3 to 5 minutes, and I'll take any questions that people have, whether you want to put them into the chat option, the Q&A option, or you want to raise your hand. I think you have all 3 options. And there'll be an opportunity at the end also to ask questions if you have. Okay, if there are no questions, we can keep going. Again, feel free to add questions if you want. Okay, so the second part. So if you look at your outline, I call them layers or lenses to consider for levels of care. So the idea of a lens, I'm thinking of some of my kids' toys where you might have like one of those like binocular type of things, and you can flip through and you can get like a red lens, a green lens, a blue lens, and then everything looks red, green, or blue, etc. So I like that way of thinking about it because I'm going to present it to you in a pretty discrete and purist kind of way, which is not like super practical. You still have to be able to put it together. Um, but it's pretty helpful when you're first learning it, I think, to be able to think about it more cleanly. So there's 1, 2, 3, 4, 5, 6, 7, 8 different lenses that I'm going to have you think about. And I encourage you to, in a fairly organized way, push yourself to put it down on a piece of paper when you're working with your patient as to what do I know about this category. It is possible that for some patients, a certain category is not relevant, but do think about it because it forces you to be sharp. I was a volunteer EMT for 10 years, and when we were taught note-taking in that setting, they drilled it into us that when you do note-taking, you always want to write negatives, meaning write what was not there. So you might write like negative CP, which was there was no chest pain, negative SOB, so there was no shortness of breath. And so that was something that I was like, why are we talking about what's not here? So from a legal perspective, that's very important because in 3 months when you get sued and they say I had chest pain and I had a heart attack diagnosed in the hospital and you missed that in your assessment, well, I could say, no, I didn't. You did not report chest pain. How do I know that? Because I asked you and you said so and I documented that. You still had a heart attack, but that was not something we could pick up on from the chest pain that didn't exist. So that's from a legal perspective, but from a keeping yourself sharp perspective, it forces you to be methodical. And superficially, you might say, nope, there's nothing in that category. But if you're actually looking at a piece of paper and you're saying, oh, safety issues, what are the safety issues here? Well, it's not super obvious, like the mother didn't call me and say her son's holding a knife to his throat. But in the context of my assessment, X, Y, and Z did come up. And okay, let's put that on the piece of paper. It may not be a major factor in how we choose treatment, but relative to 5 other things that come up that may still filter in. So I would encourage you to be disciplined enough to really just formally put it onto a piece of paper. This doesn't necessarily need to make it into your notes if you keep notes, but I think for yourself, I think it's a useful tool, even if it's a category that you don't think is relevant. So let's talk about the first one, safety. So there's a variety of issues that come up around patient safety that we turn to a higher level of care. So in a true emergency, we're likely just going straight to a hospital in most cases. Treatment centers can and will admit you very, very quickly. Like I've seen same-day admissions. That does and can happen. But treatment centers themselves have criteria as to what kind of safety issues they will allow into their setting. Some treatment centers, for a variety of reasons, will take on very little risk. Some treatment centers, for a variety of reasons, will take on a lot of risk. But it's rare that a treatment center will truly see themselves as completely comparable to what a hospital inpatient unit can take care of. One of the key differences, by the way, is that a hospital has the idea of a locked unit. In a treatment center, there's no such thing really as keeping a patient involuntarily. We might have time to talk about some category of that, but on the whole, that's a very significant difference between a hospital and a higher level of care setting that does not keep patients involuntarily. So the first issue in terms of safety is substance abuse. That's a very significant one, and that's a very common one in terms of why people go to treatment. In the world of therapy right now, there are thousands of therapists, maybe at this very moment, sitting with a patient, outpatient, that has a substance abuse issue, but they're not in a higher level of care. Now, some of them belong in that, but they're not yet ready to acknowledge that. But there are many that don't necessarily belong there. We don't put somebody into a treatment center just because, they're smoking marijuana. Sometimes we do, but it really depends on a lot of factors. So in the context of working with a substance abuse patient, we really want to think about what level of risk does this patient get into when it comes to their substances. And there's multiple layers to that. There's the risk that the substance itself poses to the patient. Then there's also the contextual factors, because we're not going to get into the whole discussion about substance abuse in America at this point in time. But the reality is that you're not going into your local CVS and buying your drugs. You're buying your drugs in all sorts of settings that are typically less than safe. And so even if the substance itself, maybe we're not that concerned about safety, but it could be that using drugs and the places you get your drugs puts you into a lot of harm's way. And so that's a factor that relates to safety that we want to consider as well when it comes to substances. Non-suicidal, self-injurious behavior. So that's fancy words for the people that are cutters, and all sorts of other self-harm behavior. So they're not trying to kill themselves, at least not consciously, at least not today, but they're harming themselves. And that's something that we, at some point, may decide that they belong in a higher level of care. Different clinicians have different ideas as to when that's the case. I assume it depends somewhat on your training, some of your tolerance for risk, some of your capacity for support for the patient at an outpatient basis, right? So a DBT place that has a full-on team in an outpatient setting with his 24-hour coaching might be comfortable with taking on more risk than maybe a solo therapist that doesn't have that ability. Another factor in terms of safety is somebody who might harm others, an aggressive acting out behavior. So that's a factor as well that you want to consider. It's important to think about like what's going on, right? Did something already happen? Are we worried about something happening? That's something that is, it's getting, we're at an age where we're paying attention to these things a lot more. So I am more commonly seeing the question being asked, oh, the kid at school drew a picture that really creeps us out. What does that mean? And it's not so easy to figure it out. I supervise somebody, and they reached out to me recently that one of their adolescent patients, it was snowing, so not where I live in Florida, but it was snowing, and they built a snowman, and they stuck 8 of their kitchen knives into different parts of the snowman, and they put a skull as the head of the snowman, and then they drenched the snowman in, I guess, grape juice, I guess to create a very bloody effect. It was a very creepy looking snowman. And the parents had brought in a picture of this to the therapist concerned. So what does that mean? Like, does that mean this kid is going to hurt themselves, hurt other people? Does it mean the kid just watched a horror movie last night and is reenacting something there? Or they're reenacting something, but there's no intention to do anything that's going to hurt somebody. But these are things that we need to be thinking about, and more we're getting these questions asked. A couple times a year, some of the local schools would reach out to me and say, the kid drew X, Y, and Z, and we have to do something. Like, even if we feel comfortable, like everybody else in the class saw it, and their parents are going to call us tonight and say, what are you doing about that kid? And so more and more we're getting these kinds of questions. They're not so easy to figure out. But as it ties into the idea of hurting others, that is something that we want to keep on our radar in terms of safety with making these referrals. Then there is also suicidality itself, right? And again, obviously there's 1,000 different versions as to how that might show up. If your patient is saying, I have a gun to my head, I want to kill myself, you're not calling a treatment center yet. You want to call the police, CMS, whatever that is, and you want that patient hospitalized. For everything else, that gets into the question as to where, what, when do we do? And you could certainly start considering treatment centers for your safety needs. Like I said, every single treatment center has their own risk assessment when they admit a patient to figure out, are they appropriate for us? Sometimes that question is all together, and sometimes it's they're a great fit, they're just not ready. So we recommend this either hospitalizing or this other treatment center with a short-term acute stabilization program, and then we'd like to hear back from you and admit this patient to our program. The last piece I would encourage you to keep in mind is legal issues, both the potential to proactively avoid getting into legal issues. So if you're working with a substance abuse patient, it should be on your radar that depending on the nature of their use, that in 2 months they might show up, and it shouldn't surprise you that they now have a DUI or a domestic violence assault charge. And so maybe it's worth getting ahead of it and not waiting for them to be in jail. That being said, if your patient is in jail already, maybe they were arrested for drunk driving. So very often in most states, I think there exists some mechanism that you can get diverted from jail to go to treatment for something that you already did. The legal piece to that operates differently in every state. You will typically need to work with an attorney to do that. Some states have nice public options that will do that, and it doesn't cost you that much. And in some places, you're buying that $10,000 attorney just to be able to get the order to go to treatment, then you're adding on the cost of treatment on top of that. In that last case, when you're actually court ordered to treatment, that does add some leverage in terms of keeping a patient accountable to treatment. Typically, the patient has to, quote unquote, successfully complete treatment. That's a very loose definition. In my experience, the courts don't have much to say about what that looks like. They're relying on the treatment center or therapist to decide that they successfully completed treatment. And that could mean all sorts of things. But that's also a very important option in terms of rather than this person with a specific issue going to jail, maybe we can get them help and go to treatment. So those are the safety issues. So that's lens number one. And I think that, I mean, in terms of our training, we're all trained to assess for safety. And we should think about that as it relates to how we're going to be keeping our patients safe in terms of treatment. The second category is diagnostic clarification. I think that's a really, really important one. In my experience, a lot of people that end up in a higher level of care, including when they have prior therapists or psychiatrists or whatnot, we don't really know the diagnosis yet. And in fact, that's probably part of the reason why they're not yet succeeding at outpatient therapy, because we're treating the thing that we don't quite know yet. And so we really want to be able to get better diagnostic clarification. So again, there's different versions. There's a patient that we know has an issue. We have an approximate sense as to what's going on. But if we're being honest with ourselves, it's just not quite adding up, either diagnostically or treatment-wise. Or you have new patients that something's going on. They haven't been meaningfully in treatment yet. They do warrant a higher level of care for other reasons. Maybe it's safety. And we do need to figure out diagnosis. Another complicated piece is substance abuse. So substance abuse can induce just about anything. So if you look through the DSM, just about every single disorder has, as a rule out, substance induced, and then it fills in that name of that disorder. Meaning substances can create almost any single effect that you could otherwise see as a mental health issue. And so if a patient is using drugs and then experiencing symptoms that look like depression, anxiety, OCD, whatever, psychosis, you want to make sure what's causing it. Is this what we would call an organic mental health issue? Or is this substance induced? Those are two very different patients, and the treatment looks very different. And that's an important piece to figure out diagnostically. That too is where a higher level of care comes in, because to now effectively make the diagnosis once the patient has used drugs, we need to get them sober long enough to see what sticks around. And that might be very hard to do at an outpatient basis. So although technically speaking, in most treatment settings, you're going to give the patient a diagnosis literally within the first 24 hours. So most, if not all, treatment centers have an intake, often called a biopsychosocial assessment. It typically fits a fairly standardized formula. A lot of it is geared towards what insurance is looking to hear about. And you're going to have to give a diagnosis. Like, you just can't bill insurance without a diagnosis. And that happens in day one. But in my mind, clinically speaking, in some places even let you, so to say, specify that, you might be giving what we'd call a provisional diagnosis, which is to say it's subject to change upon review. The problem is that in all practical purposes, a lot of places don't ever really take seriously the provisional part, and they continue to treat you as is without rethinking whether anything's changed. But in concept, if certainly if somebody's coming in and you just detox them, you should not be giving them that diagnosis of, let's say, schizoaffective disorder, unless you really know from their prior history without the drug use that that's really what they have. So again, you can put down the diagnosis if that's what they look like today, but make it provisional, and you're going to keep reassessing. So there's different ways that treatment centers or clinicians do assessment. So for example, where I used to work, we offered psychological assessment, right? So a psychologist does 2-3 days of testing with you and then writes up a report. As a rule, we would not do that until the patient was sober for 30 days. Like the data that you got in the first 30 days was truly irrelevant, or we should say not valid. After 30 days, you could do testing and you'd come up with a diagnosis. We still held to the standard, though, that until the patient's been sober for a year, it is not a true diagnosis. And most patients didn't stick around by us for a year, but we made it clear in the testing feedback session to the family that this is the working diagnosis. Now that they've been sober for 30 days, it is pretty reasonable to assume that this is actually now, let's say, the mental health issue. It's not just substance induced. We're going to continue treating them with, let's say, an antipsychotic and mood stabilizer. And but you should really consider getting retested in a year. And people are desperate for that because most people are hoping it's substance induced and that the issue goes away after the substance is cleared and you don't have a lifelong, let's say, schizoaffective diagnosis. That being said, keep in mind that that's not always going to happen. People do have this myth that substance-induced such and such thing will go away once the substance clears. That is not always true, meaning sometimes it stays forever. I believe there's two reasons for that. One is because not every substance-induced, let's say it's psychosis, goes away when the substance clears. It just started something that's not going to end just because you stop taking the substance. It's not like it's a gas tank and you've run out of gas. The other factor, and I mean, to the extent that I follow this research, it doesn't seem like we yet really know the answer, but it does seem like, at least for some of the substance-induced patients, so let's say Michael had substance-induced psychosis. So Michael's 19 years old. It could be Michael was on track to develop schizophrenia. Let's call it on a genetic level. And it would take something from the environment to trigger it. So for some people, it might be a traumatic event. In Michael's case, it might be the drugs that he took. And so even as the substance clears, he is still left with a diagnosis of schizophrenia. And the substance might have tied into triggering it, but it triggered an underlying organic mental health issue. So people are very hopeful that when their 19-year-old kid that seemingly never had schizophrenia before has psychosis and they were at some party and did drugs last week, they're hopeful that in a month of acute care, they're going to come out and be healthy for life. For some people, that may never be true in the sense that they'll still have schizophrenia despite the best treatment that they get for that. But in terms of the process of diagnostics, again, you really want to get, whether you're doing formal assessment or not, but you really want to keep in mind that for the first 30 days, you're still maybe not detoxing in the strict medical sense, but you're clearing these drugs from your system. At that point, I think you can more meaningfully look at diagnosis. And if you're doing formal assessment, again, very often the standard is do testing after 30 days and then retest after a year. Some people we'll call it the good news after a year, that they seem stable. We're going to start weaning them off of their antipsychotic. And hopefully we can see that they continue to do okay. And that kind of proves that it was just substance induced. And some people at that point, we feel like we could try, but as we wean them off, that just continues to be impossible. And at some point we settle that this is schizophrenia at this point. We don't know if the substances triggered it, that we're going to get it anyway, but that just is what it is at this point. So diagnosis is very important. So the different reasons why diagnosis is hard to make at an outpatient basis is there's a lack of data points. I mean, I do outpatient therapy, so to say, in the regular way, separate from my treatment center work. I love my patients. I think I know them really well. But the reality is I see them for typically an hour a week. And so it's something that's just very limited. And it's heavily reliant on what the patient chooses to bring into session. And so if you're talking about a patient that's a poor historian, has limited things that they can share, so that's something that becomes very difficult as we're trying to get more data points, especially, and this is maybe well, it takes place for mental health and substance abuse, but patients will conceal information for a variety of reasons, whether they won't report psychosis, they won't report drug use, for fear of they don't want treatment, they don't want to get in trouble, whatever it is. So we're lacking data points at an outpatient basis. Um, then there's also there's less qualified providers. There's great therapists, great psychiatrists at an outpatient basis, but for example, let's take schizophrenia. Your average outpatient therapist is probably not really competent in working with schizophrenia. It is a more specialized thing that, for a variety of mostly, I'd say, training and systemic reasons, your average therapist outpatient doesn't have much experience with it. And so, if it's a full blown psychotic episode in front of them, so maybe they could label it as such. But if it's more like under the radar psychosis, which does exist, they might completely miss it, or they might see it and interpret it as something else. And so you are somewhat more limited in terms of what you're going to get outpatient in terms of being able to make that diagnosis. Then this is another big one. It's a systemic issue. There's a lack of care coordination across providers. At the most basic level, that's between psychiatry and therapy. I encourage you to all ask yourselves, if you have a caseload of 5, 10, 15, 20 people, ask yourself how many see a psychiatrist, and when was the last time you spoke to that psychiatrist? In many cases, it's never. In some cases, it's once. And if you did speak to them, what was the quality of that conversation? Did all you get out of that was which medications they're on? Or was there a really robust, rich clinical conversation where the psychiatrist actually saw you as an ally, not just as an underling, and you reported on what you saw, and the psychiatrist valued that? And vice versa, that you were able to hear from the psychiatrist certain things that are relevant for your treatment. I think that's very, very rare that that happens for a lot of reasons. It has nothing to do with people being good, bad, well, or poor intention. I think it's mostly systemic. A lot of it has to do with time. We're all busy. We all are trying to get paid for our time. And between those two things, I think it makes it very hard to actually coordinate care, amongst other issues. But I think that's a problem as well. The patient could be less cooperative. They could be a poor historian. And you get to a higher level of care, not magically, but all of that now changes. You have tons of data points. Like I mentioned the tech staff before. When I would walk into the treatment center in the morning, I would have the shift reports from the tech staff. Now, I think most of my colleagues just deleted it. I tracked it. I actually got 1,000 emails a week on average when I worked in residential treatment. I know that because when I came back from vacation, that's how many were in my inbox. That's a staggering number, and it's ridiculous and it's not functional. And so pragmatically, many people just learn to delete things and don't actually read them. But I thought those tech staff reports were amazing. We had 3 shifts, so 8-hour shifts, and they were all just packaged together as like a daily report. And each tech staff person who did rounds on the patients would write in the reports. And a lot of it was not super important. It was just, normal day-to-day stuff. But there was gold stuck into a lot of random places that you had to look for. And again, I can't emphasize this enough in terms of the tech staff. I have a doctorate. I spent a god-awful amount of time and money on my training, and I know a whole lot of different things. But the tech staff, like I said, who may not have graduated high school, they know a lot too. At the very least, they might be in a setting with 50 patients at any given time, and they, at the very least, know what's different between Rachel and Mary, and what's different between Rachel of yesterday and Rachel of today. And they're pretty good at reporting that. Again, a lot of the reporting is, well, if nothing happened, it's pretty benign. Mary showed up at the process group. Okay, like that doesn't interest me that much. That's like normal. But I'm more interested in when Mary didn't show up to process group. What was she doing when she was hiding in her room? Well, I don't know that. I never left the clinical building. And it was very, very informative. And there was a lot of data there that helped in terms of diagnostic clarification because we really got essentially a 24/7 report from them. And then separate from myself, we're all talking to each other at a treatment team meeting. There's me as a psychologist, there's a psychiatrist, there's a director of nursing, there's a director of the residential department, there's the weekend staff. So there's really an ability to get a very nice cross-section of data that we can pull together. I can't speak for any other provider in a treatment center, but I saw my role as a primary therapist or even as the family therapist to pull together that set of data. In concept, I could suggest that it should be other people's role as well, but I took that responsibility on for myself, that it was my responsibility to ensure that somebody was looking at the collective set of data and putting that together, which was why on a weekly basis, I was meeting with a psychiatrist to talk about my patients. And we had a very great collegial, cordial relationship. He was more than happy to hear from me, as was I happy to hear from him. He fully recognized that I see the patient and or read about the patient a lot more than he does. And he has a certain expertise in terms of medication, but I had a lot to offer in terms of what was going on and how to think through it. I think that I mentioned psychological assessment. Not every program does it. And the programs that do it, some of them do it in-house. Some places contract. Right, you have to be a doctoral level psychologist to do most forms of testing. So a lot of treatment centers don't have doctoral level psychologists, but a lot of them will contract with other people. There's different kinds of assessment. There's, we'll call it general psych assessment that might include personality testing. Some places focus more on like getting a good neuropsychological assessment, which will focus more on cognitive issues. But that could be a pretty important piece to the process as well. Again, it's not something that's unavailable at an outpatient basis, but when you're doing it in-house, so the person doing the assessment, like I said, there's all that data. As their background, they can get all that data, and I think that helps fine-tune the nature of the assessment that they're going to do as well. Okay, psychiatric care. That's a very important piece. It overlaps a little bit with the diagnostic category. So at a treatment center, you're typically going to have access to well-qualified psychiatrists who could really handle serious and persistent mental illness and substance abuse and everything else in between. You don't have that with your average outpatient psychiatrist. Your outpatient psychiatrist has the training that they could technically diagnose schizophrenia, but many of them haven't touched it with a 10-foot pole since their residency. And they'll tell you that. They will say they will not take a patient with schizophrenia. They want a quiet, simple outpatient life with anxiety, depression, and let's assume that's it. One of the psychiatrists phrased it to me as they wanted the worried well. The healthiest patient that has a neurosis, and they'll prescribe them their anti-anxiety, and that's about it. They don't want to be on call for anything, etc. So a lot of times you're going to struggle at an outpatient basis to get a psychiatrist that can really handle the range of the stuff that's going into higher levels of care. Now, this is an area that I do want to give you some guidance on. You're going to find a range of ways in which higher levels of care manage who the psychiatric provider is. Which is to say is that let's assume your first encounter with the treatment center might be their website. Meaning if you're not regularly in this space and meeting with treatment centers and touring treatment centers, you likely are going to find them, let's assume, on the internet or somebody told you about it, but you're going to go to their website. So you're going to go to their website and you'll see that there's typically what we would call a medical director. That's, I think, the most standard term that you'll see. The medical director is often a psychiatrist. The other thing I've seen is a family medicine / addiction medicine doctor. Those are the two most common things I've seen. So they're in charge. But what does being in charge mean? Now, I haven't run a treatment center. I don't know that I know the technical answer to that. But they certainly, their signature appears in a lot of paperwork. I see their signature very regularly. They're signing or counter-signing all sorts of different things. I assume in terms of accreditation that matters. But whether or not they see patients really, really varies. And I think that's really important to find out about. More and more, I'm seeing the treatment centers are relying very heavily on psych nurse practitioners. Now, I don't have a problem with that per se. I'm not saying that is inappropriate and or not good for your patient. But I do think it's important to think about what your patient in particular needs. So one thing to keep in mind about psychiatric nurse practitioners is their training path is vastly different than psychiatrists, and in fact, you as a therapist as well. Which is to say is that I believe many of them, certainly many of the ones I've met, they started off as a general nurse. Then they decided to get a nurse practitioner degree, or maybe they got the nurse practitioner degree right away, right, that advanced degree. But their psychiatric training is heavily based on a system of, their technical term is preceptorship, right? So we might call our trainings field works and internships. I believe the term they use is preceptorships, where they're going straight into a clinical setting. And it's essentially an apprenticeship where you're working clinically under somebody. If you think about it, that's very, very different than you and I may be sitting through a psychopathology class and processing cases in supervision. It's very focused on the tactical, on the ground kind of setup. Now, that's as like a whole. I can't speak for any single individual nurse practitioner and what they, chose to learn more about. But if we're looking for the psychiatric piece to really delve into diagnostic clarification, to me, that kind of training doesn't readily lend itself to that. Meaning they're going to be able to tell you if the person's flagrantly psychotic. They might have a fairly solid grasp on the medication and the dosing and all of that, but I'm not sure they're that helpful to me right now in terms of diagnostic clarification. Whereas the psychiatrist really does have that at a very sophisticated level. Now, this is not necessarily true for everybody, and you could and should look into it more specifically for yourselves in the places that you're going to try to connect with, and also whether or not that piece is very important for your patient. But you should be thinking about it. And keep in mind, it will not be readily apparent on a treatment center's website how they're actually using these people. So as I've interfaced with treatment centers and I ask them these questions, I get very different answers. Sometimes the medical director literally does not really come on site. They're there on paper. Maybe they come on site once or twice a year. They sign things. Maybe they review notes remotely. Maybe the nurse practitioner has access to the medical director to consult on cases. But by and large, it seems fairly likely that the patient is never going to see the psychiatrist. The psychiatrist may never really hear about the patient. And we need to then know if the nurse practitioner is really capable of doing this work with the patient. Now, I mentioned earlier about the idea of the fit and not about the best program. So if you were asking me to design a program, I probably would say that every patient should see the psychiatrist at least once for the initial assessment. Let's just make sure we really have diagnosis figured out, because otherwise a lot of it will continue on autopilot for the next 1, 2, 3 months. So let's just really make sure that we get that part right in the beginning. But that's how I would design a treatment center. That may or may not be what your patient needs, meaning you may send a patient that you have not a shadow of a doubt about the diagnosis. It's always worth keeping an open eye, given that you're going to get a lot more data in treatment, but you're confident with the diagnosis, and they've been on the same meds that they've been stable on. There's another set of issues and reasons why you're sending them. So in that case, I'd say it might not matter so much. No problem. Let them see the nurse practitioner the whole time. Or maybe you know that this nurse practitioner is much more qualified than maybe some others are. She has more training that she's done, or she does consult rather closely with a psychiatrist. So I'm not ruling it out. And I will also just tell you that lots of things in treatment are negotiable. I'm not telling you to be a pain in the neck to every treatment center that you call, and some things are not negotiable. But in my experience, I've asked for this. So there are treatment centers that I think are running great programs, but the patient I'm sending, I think, needs to see a psychiatrist. So I'll ask them, can you have this patient see the psychiatrist for the intake? I'm fine if they see the nurse practitioner afterwards, but I need them to see the psychiatrist for the intake. I have not yet been told no to. And again, I can't decide that for any treatment center. They have to decide if that's worth their time, money, and effort. But that's something that on a case-by-case basis, that's worked out fine for me. I don't know that they're willing to do it for everybody. I mean, there are clearly economic factors that tie into the choice between using nurse practitioners versus psychiatrists. But again, I think it's if you can have a high quality conversation about your patient's needs, I think you can sometimes advocate for the things that you think might be needed. Again, do it respectfully. Make sure that you know what you're talking about in terms of your case first. Make sure that you understand what they are or they're not offering, and then you can follow up from there. In general, I would encourage you also, somebody actually asked in the chat a question about a trusted website that you can suggest to see a list of possible programs. I don't know how you define the word trusted. We all might have different ideas as to what trusted means. By definition, I would assume that you realize that the website of a treatment center is both an educational tool and a marketing tool. And that's fine. That's what it should be. My website would also be an educational and also a marketing tool. A marketing tool doesn't mean that somebody's lying to you. I think it's trusted in the sense that they're being honest, but any marketer will tell you across any business that they're highlighting information in a way that's designed to bring you in the door to a set of something. So I think it's important to look closely at what is being said, what's not being said. And again, not because that makes a treatment center good or bad, but about what makes it a fit for you. And, I just want to make a comment. I keep stressing fit so many times. And it's important because if it's not a fit, it really isn't going to work out for anybody. A treatment center may say yes to you, but it's really not going to work out well for you because you're going to create a ruckus in the milieu setting if the patient's not working out there. And the milieu setting is very sensitive. Like slight disturbances very significantly impact other patients and creates a good or a bad treatment environment for them, you're going to be a very frustrated consumer having spent this money on something that's not working out. And the treatment center, even if they're making money off of it, they're not going to be happy with it either. It's taking up an inordinate amount of their time trying to take care of everything. So I think that it's in everybody's interest that you really find the right kind of fit. Okay, so somebody asked a question, can you discuss clinical decision-making and when a client needs a referral for a higher level of care? So you could feel free to share more about what that question is, but in the way that I'm understanding it, I think that, again, this idea of these 8 lenses is designed that by the time you've encountered all of them, and we're a third of the way through, that by the time you've encountered all of them, you will be able to make that decision for yourself. Meaning, I don't think that the idea of going into a higher level of care very neatly fits into a strict protocol. I think that 5 different clinicians could reasonably make very different decisions as to whether a client needs a higher level of care. I think there's some super obvious cases. Like I said, the patient that overdosed, they're in a coma, they're in the hospital for a week, they're now awake. It's probably a pretty reasonable bet to say they belong in a higher level of care and not ship them straight back out to outpatient. But a lot of, a patient that has failed outpatient after 10 years, I think it's time to start really thinking about that. But there's a lot of patients that fall in between. And again, like I mentioned in the beginning, too often people go for the crisis only. And again, those to me are the more obvious cases. I'm encouraging you that treatment centers should be looked at much more proactively and strongly well before we get into crisis. So I think that what I would suggest is that if you're, so to say, keeping these 8 different lenses in mind with a patient, you're going to start getting a sense of how well is outpatient working to answer the set of issues we have in these 8 different categories. And remember, there's always competing factors outside of this. For example, cost. No matter what I told you about cost, you might have some families that will continue to resist paying for this level of care, even very wealthy families. I worked with people who are billionaires who don't want to be paying for this kind of care. So it's not just about what you can technically afford. So there are always factors outside of what you're determining. But you're asking yourself essentially across these different categories, how well is this working or not? And at some point, you as a clinician will have a threshold for this isn't working well, and I think I'm running out of confidence and belief that this will work well, even if we give it a little bit more time. And in that sense, you make that decision as a clinician all the time. You've tried a certain, let's say, a specific CBT approach. At what point do you decide it's not working? And either you're switching the patient to a different therapy type that you offer, or you're switching them to a different therapist, or suggesting something else. Maybe you think it's time that they started medication as well. So there's not like a strict protocol as to how to do that, but I think you're asking yourself, how well is this working? Is it still reasonable to think that the change that I'm looking for might happen? The subset to this question is which of the higher levels of care? So we talked about IOP, PHP, and residential. Honestly, I think that has a lot, if it's not super obvious, which in some cases it should be, maybe based on safety, some patients need 24/7 monitoring, then I think a lot of it has to do with, I'd call it your value system as a therapist. And one key difference I find, and this is not just as a therapist, I think this shows up in parenting types, personality types, but are you proactive or reactive? If you're proactive, you're going to be looking at a higher level of care much earlier, which is why you might be looking at IOPs. Your reactive colleague is probably looking at residential only, because by the time they're ready to do something different than outpatient, the patient might only be appropriate for a residential treatment program. So I think that the determination as to which of the higher levels of care often depends on when you're getting into the mix. And remember, we talked about which order. Are you going bottom up or top down? So if you're going top down, by and large, you're going from residential through the continuum. Most people I'd say are going from res to PHP to IOP. You're typically not skipping steps, although that does sometimes happen. But if we're talking about the more nuanced version where you're going from outpatient all the way up into residential, then if you're reactive, you just have less options. Like you've exhausted them. You waited too long at the outpatient basis, and the safety issues are too strong at this point. If you're going But if you're proactive, then you might have options. So let's say you're struggling with diagnostic clarification and you decide it's just not working at this point. Like, I can't figure this out. I'm missing something. I know it. Something's not clicking here. Let's say you're a good therapist and you consult with a colleague, with a peer supervision group, whatever. Maybe that helps. Maybe it still doesn't. Not because nobody's good, but you're just missing the data. You don't have it on an outpatient basis. So you might say, I think IOP will give me that data. I just need the patient monitored 10 hours a week. I don't need 24/7. That's a fair decision. Let's say it's about psychiatric care. And so you might say that the patient needs med compliance that I can ensure on an outpatient basis. But it's not that the patient won't take the meds if it's presented to them. I just can't trust that they'll take it on their own. So if you put them in a 5-day-a-week program, it could be that that does the trick. It's an IOP program. They show up 5 days a week. The nurse there gives them their meds, and they're okay. But some patients, maybe they won't take it altogether. Certainly not in the IOP style of giving meds. And so maybe you do need residential for that factor. So again, I'm encouraging you, I'm trying to empower you to think through it. There really is no easy solution. But you need to think through based on what you know from your intake. And again, you'll all have differing relationships to the patient situation. Sometimes it's a bit more third hand, the parent's calling you, you don't have direct access to the identified patient. So you want to really be thinking through these different lenses, what's working, what's not. And again, largely, I think often enough based on how proactive versus reactive you are, how well this is going to work. Somebody asked the importance of using the ASAM criteria in determining appropriate levels of care. When I worked in treatment, that had to be filled out for every patient, and I forget the timeline, but you used it in the beginning, and then there was, I think it was maybe every 30 days you had to redo it. I don't think I've ever used it once at an outpatient basis in terms of determining it. I would guess if I looked at that form today, I've probably incorporated a lot of it just into the way I think about care, even if I'm not methodically looking at that box. I think that's a bit more standardized in the way that I understand how it makes sense in terms of regulations and the insurance piece and accountability. I think for myself, the criteria I came up with, which are these 8 lenses, I think for me has been far more helpful in terms of working it out, practically speaking for myself. But I think it's a very good way to get organized, either in addition to or alongside what I'm proposing for people as well. So I would certainly encourage that as well. Okay, I don't see more questions, so I'm going to jump back, and we're now talking about the fourth, we're finishing the third lens of psychiatric care. Another benefit in terms of psychiatry is you have good ability for follow-up. At an outpatient basis, if I went to a psychiatrist today and they gave me a prescription, that doesn't mean I took that medication. That just means I walked out with a piece of paper. I may or may not ever fill that prescription. I may fill it and I may go away for a weekend and I forgot my meds. And now it's somehow a week later and I still haven't taken my meds. Or I'm having a side effect. And I see this all the time. People just discontinue their meds with a side effect. Many of them don't bother calling the psychiatrist to discuss it and work it through. Many don't have the tolerance to deal with the side effect, even if it might be worth it relative to the gain. And so that's something that can all be fairly easily done in treatment because you have so much more access. And that's where I think the nurse practitioners are very helpful, because it isn't realistic, certainly not financially, for a treatment center to have a psychiatrist available 24/7 in the way that they can have nursing staff there. And for this piece, I think that the nursing staff, I think, does an excellent job with the side effects. If I think about, at least stereotypically, some of the original ideas about nursing in terms of like bedside manner and care, I've seen the nurses in treatment centers do an amazing job getting patients to be med compliant in a way that the psychiatrist is not going to ever do. They build a real rapport with the patient. They have the time to spend with them. They're very creative and flexible in how they build a rapport. So I think that's a very nice human side to how that happens in a treatment center as well. And additionally, and I alluded to this before, but the psychiatric care in a treatment center has a much better ability to interface with every other aspect of care in the treatment center that doesn't happen on an outpatient basis, whether it's the psychiatrist getting more data points, whether it is the psychiatrist being able to monitor side effects and so forth. Another aspect of psychiatric care that's important is the ability to consider more serious levels of psychiatric intervention. We've seen a proliferation in the last few years of a lot of different modalities that certainly were not, they didn't exist, so they weren't part of psychiatry's wheelhouse. But now that they exist, for the most part, are falling under psychiatry's wheelhouse. So things like TMS, ketamine, ECT, these are things, I mean, ECT always existed, but there's like newer versions of it. These things are becoming very popular. I mean, I would say that they're exploding in popularity in different settings. They do exist on an outpatient basis, but for certain patients, it could become much easier to facilitate that in a treatment center. I would encourage you to be mindful that these things end up taking up a lot of time, and you really want to be mindful as to the balance of how much time this or that modality is going to take relative to the amount of time you think they should be in the treatment center doing the work that the treatment center typically does. For some patients, I think it becomes a distraction from treatment. And if we think about prioritization, and again, that's an assessment you need to make, they could fairly easily do this particular, let's say it's TMS. Maybe it's more appropriate that they do it when they're in PHP or IOP, not in residential. Let's get them stabilized in other ways first. So it's an amazing ability, but be judicious in how you use it. Okay, that's psychiatric care. The fourth lens, behavioral change. It is incredibly difficult in an outpatient setting for a significant subset of people to change. We know that. As therapists, if we had to define what we do, I'd say one of the most standard definitions is we help people change. And that is incredibly, incredibly difficult. People don't change that easily. And even in therapy, people don't change that easily. And for a subset of people, that change needs to happen in a higher level of care. And the difference is, like I said, helping people change often relies on data. It's hard to get that outpatient. There are more ways to get data these days. There's a lot of apps that have cropped up that, you know, your therapist has an app, they assign you certain tracking sheets, you get reminders to fill it out. That helps, but it's not enough for some people. It doesn't move the needle enough. Then you need to be able to follow through, right? I mean, sometimes you have therapists that are using these apps, they're getting fed all this data, but they haven't really set themselves up to review it. And then the patient gets sent a certain kind of homework based on that. I suspect it's going to change as AI is coming more into play. There might be more automaticity that the patient fills out certain things. AI then has the ability to push certain things automatically to them. But again, I think we're still limited in that in the way that the treatment center, you know, I could sit there with a patient, I could have walked in at 9 o'clock in the morning and get data on their entire previous day that I didn't see directly. I could then sit with them and I can figure out something I want to do differently. And then before I leave, I can speak to the tech staff and ask them to make sure the patient does X, Y, and Z. So there's a much better ability to integrate the data and the behavioral change interventions in a way that does not exist at an outpatient basis. And in addition, the environmental change that's often needed doesn't exist, but is often hard to make happen on an outpatient basis. So one example I often see, I'm a big fan of the whole world of AA. It's not for every patient, but I think most of our patients should be strongly considered to try it out in a very serious way before they decide it's not for them. That's certainly true for substance abuse, and I think that's true for a lot of other patients as well. And I'm including the broad spectrum of AA and AA type programs. So even things like a NAMI support group, a codependency group, things that are somewhat similar, I think that could be very useful. Very often, so you have the patient and their wife is now the one that becomes the nag every day. Did you go to your meeting? Are you going to your meeting? Did you talk to your sponsor? And that creates a lot of friction in the relationships. And again, when it happens in an outsourced way in treatment, oftentimes that goes a lot better. Okay, the next lens, therapy modality and type of intervention. So we're in a day and age where we have a lot of different therapy types, and some have been around forever. There's just minor tweaks, some seem newer. And there's the popular ones. I mean, I'll mention two that are like super popular now. There's DBT and EMDR. Those are very, very popular modalities, and you'll see on treatment center sites as well that a lot of them are trying to offer these modalities as well. So if you think your patient needs a certain modality, some of you live in a place where you have ready access. You can easily refer them to a therapist of that type. There is an explosion of online therapy now, and more that's less of a barrier. But like I said, not every patient's appropriate for online therapy, so that's not always the solution. So sometimes your patient needs a certain modality type or multiple modality types, and you can only get them in a place as robust and comprehensive as a treatment center. I do want to caution you, make sure that they're really trained to do that. A lot of places are getting into what's buzzy and trendy, but they're not really investing in the training for all of this. So that's something that's important to figure out. As well, treatment centers often have the ability to add in a lot of different types of alternates to regular therapy. Things like art therapy, dance movement-based therapy, things that technically exist outpatient, but it's hard to sometimes find them. And then treatment centers utilize a lot of group therapy. Some people are skeptical about this and see it just as cost effective. I'm a huge proponent of group therapy. I think it's amazing. And that's not to say every group and every treatment center runs brilliantly, but group therapy is a very, very powerful tool. And when done right, it can be really helpful. And in my experience, it's sometimes hard to find group options for patients. So that's not going to be the only reason why you send a patient to treatment, but that's a very significant part to that as well. The next lens is family/environmental issues. In a sense, we're looking to create a bubble for the patient. Many patients just need to be put into a certain bubble that's much more sterile in a sense from everything going on in the world out there. And that's a very important piece. There are some family relationships that are very dysfunctional. They could be nice people, but it's just not working out. Sometimes that was pre-morbid. Sometimes they could have been great, but now that the issue's been going on for months or years, this is really not working. Sometimes it's friends or school, the work environment. Like, I don't know, in the papers, like they were talking recently about the issue of drug use amongst attorneys or on Wall Street. Like sometimes you're in environments that's just not conducive to change, and you need to get out of that environment. People from like a trauma sense maybe have too many triggers in a certain environment. That can also be hard. And putting people into a certain bubble allows you to create a certain kind of deep reset. Second to last lens, an interdisciplinary, multidisciplinary approach. This is a very buzzy word. I think it rarely happens. Most places that call themselves interdisciplinary, I think, are really technically multidisciplinary, which is to say is that you have 5 different specialties. They're all working in the same building using the same note system, but they're not actually collaborating together. And in a treatment center, you are much, much more likely to get that kind of collaboration. I mean, this is something that I have less access to. I mean, you have to sit in a treatment center's team meeting to know what that looks like. And most treatment centers do team meetings in a very serious way. But the nature of those meetings varies in terms of how much collaboration maybe happens. But it's a very important piece that's very hard to do at an outpatient basis. And so I think that that's a huge piece that you want to think about in terms of what are the things that my patient needs that we're not able to do, even if I've taken the time to make sure my patient has a psychiatrist and an OT and maybe a neurologist, but do we talk together? Probably not. And if so, that would be really cumbersome to pull together. So that's a very, very important piece as well. Last category is comorbidities/dual diagnosis/complex diagnosis. So we talked about that a little bit diagnostically, but I want you to understand that from the treatment standpoint, that's also really, really difficult to treat at an outpatient basis. It requires so much ability to integrate data and treatment in a way that becomes really, really difficult at an outpatient basis. And I think that treatment centers are much, much more equipped. Again, it varies at the level of care, and you'll make that decision which one of those levels, but it's something that is really, really difficult for outpatient to be able to treat effectively, and treatment centers can do that well. In my experience, a very common presentation where I worked in treatment was a trifecta. You had a substance abuse issue, you had a borderline personality disorder, and bipolar disorder, all wrapped into the same patient. And that's a complex patient. Like each of those 3 different things are serious in their own right. And we know what they look like in their own right, but they mix and swirl in very unique ways that make it very hard to treat. And I think in a treatment setting, you actually have the capacity to really do all these things together. So you have 8 lenses at this point. Be methodical, go through them as it relates to the patient you have in mind. And again, not every category is relevant to every single patient, but you're going to come away with a whole lot of information, or maybe questions, but you now know what you need to assess for. And I think you'll then be able to have a sense as to, is my patient doing well enough at an outpatient basis and they're fine? Is my patient not? And I want to be proactive and move them on. And now I'm figuring out which of the higher levels of care. I would give yourself a lot of time. Even if you feel confident that you have the right place and it's going to take a week to admit, the family might take 6 months to figure that out. call any admissions office in any treatment center, and they'll tell you that we have everything ranging from same-day admits, and we have some families that we've spoken to every day for 6 months, and they're not yet admitting, but they're still talking about it. So people need time. It's a very significant step for a lot of people to go into treatment, even an IOP for that matter, and people need time. We're going to stop here, and people have questions, they can jump in. Google my name, you'll find my phone number, email somewhere if you want to follow up. I hope you enjoyed, and thank you again to TPN and Sandstone for hosting, and I'll take any questions that people have. Okay, so somebody asked about intensives. Do they have to be licensed like the hospitals? I believe the answer is no, in that they're setting up very different programs. And the licensure, let's say for a treatment center, the technical term we use is a residential treatment center, an RTC. That's a certain kind of accreditation and licensure, which most intensives don't get set up that way. It also depends on where the intensive chooses to house themselves. Sometimes a treatment center will put themselves into, will also open an intensive program, and maybe that accreditation falls under there. At the very least, I would say if your intensive is being run by a therapist, which most of them are, the therapist should be licensed. You should make sure that the therapist is credentialed the way they should be. And as well, you could always ask, meaning licensure means that somebody else has done the work for you, vetting them by a certain set of standards. But you might, after walking away from this presentation, decide that I have my own questions and thoughts as to how this place should be, what standard they should go by. Call them up and you can ask them about it. They'll tell you. Somebody else asked a question. How do we handle a situation where clinical staff does not agree with a court order where an adolescent is being ordered to residential for THC use? So let me see if I understand this. So I'll answer it in the way that I understand it. If there is a court order, it doesn't really matter what anybody else thinks. I mean, that's the law now in this case for this particular person, and that is going to have to be followed. Now, the reality of the court deciding something and that being carried out, there's definitely a gap across any sector of the legal system. All right, the court can say you have to obey the traffic signal, and you may choose not to. So what people do is their own choice. But in concept, if you're choosing not to agree with the court order, somebody's going to be in trouble for that. So I'm going to assume that if there's a court order, it has to happen. The question is really just how it happens and who does what. Typically, though, I think that in my experience, the court doesn't claim to know anything about mental health. Now, there is sometimes specialized courts that deal with mental health, but as far as I know, the judge is not a mental health clinician. They just have some more experience with it, and certainly the legal side of it. So they're interfacing with a clinical team. In my orbit, when I've done work that interfaces with the legal side, the court's turning to the clinicians to say, what do we do with this in terms of the clinical piece? Then the court decides if what you've told them meets the legal criteria that they have. So again, if the court said this is what it is, and it is what it is, if there's an appeals process and you want to go through with that, you could. And if it's about a clinical disagreement, my hope is that there's a space when there's the assessment that the court's going to rely upon, that could be meaningfully discussed. There's a question, when or if does it make sense for a patient to return to you or not an outpatient after these programs also check-ins during the treatment? That is an excellent question. I think it really depends on your role. So people who go into treatment, some of them come, we'll call them self-referred. They themselves decide to go. That's not relevant to our question here as much. In your case, so the question is, are you the referent or the therapist, or maybe both? There are people that specialize as referents. We call them often ed consultants, interventionists, etc. They're not typically working with a patient either before or after, outside of that specific role. Some of them will continue to work with a patient, maybe even like 6 months after treatment, but not really as their therapist. They're kind of working to make sure that things are still running and they can connect them to resources if they need. In terms of you as their therapist, I think it depends. If you had a good working relationship and you've managed to maintain that, which may not be so easy, and that's sometimes the bullet that you bite in terms of getting a patient into treatment, because that's what they need. But if you have that relationship intact and you're still appropriate for them in the sense that clinically they're now stabilized to the point that they'd benefit from continuing on with you, no problem. I think that's great. I mean, in general, I think the longer a patient can have access to their same therapist, if it's working, I think it's really good. Treatment centers, I think, are typically mindful and very respectful of that, especially if you're clear about that from the beginning. Remember, treatment centers, I don't know about legally, but all treatment centers will work very hard to set the patient up for a good discharge plan. We could debate how good those plans are, but they will certainly all try to create. Patients rarely leave a treatment center without a discharge plan in place. So it is important, if you're referring, to have that conversation up front, and they'll sometimes ask you directly, but you can say, I just want to make sure when the patient is done with treatment, I'd like for them to return to me. Obviously, that's pending different clinical factors, but before you go and make a recommendation to somebody else, I would like to be part of that process to figure that out. So that's what I would say to. Oh, and check-ins during treatment. Again, it depends on your role. So some interventionists that place people, they might just place them and never check in, like call me if you have a problem, but I'm not checking in. Many of them, though, will be on weekly calls with the treatment center to keep track of progress, in part because they're also going to be involved in discharge planning and they want to know what's going on. If you're the outpatient therapist, some therapists at that point want to just step back. Oh my gosh, I've been working with this person for 5 months in this acute stage. I'm so glad they finally got into treatment. I need a break. And that's okay. Like, they're safe in treatment. You did your work. If you can handle it, it might be nice to call once in a blue moon. But it's okay to say, like, I've done my job. I can't be effective at this stage. I need a break, especially if I'm going to take you back. We need to have a cool off period. You'll decide how you say that to the patient, but I think that's fine. There is also the version where you're not in touch with your patient, you're just in touch with the treatment center. They'll offer maybe to email you a weekly report. They'll offer you to be on a weekly 15-minute call with the therapist. If you want to get into the weeds of like the psychiatry, they'll typically make somebody available to talk that out with them. A lot of that might also depend on the family you're working with and how much they want you involved. Sometimes you might know the family better and the family still wants you to be a liaison. So it's largely up to you. Treatment centers typically on their website will have a page for referring professionals, and you'll see how they format what they would like to be doing with you. But aside from their standardized approach, they're often fairly willing to work with you in the way that you want to work with them. We're at time. I'm scrolling through. There is some questions. Do I have time to answer more, or do we have to end?
You can answer more.
Okay, so let me see what we got here. Okay. A court order, do the parents play any role? So again, I'm not an attorney, so I can't specifically answer this. And also, you should understand that every court operates in a different state and county, and the rules vary significantly across locales. Again, everybody has a role. So the court plays a legal role. They determine what's going on and does this person meet criteria for X, Y, and Z. They are relying on a clinical somebody to tell them what's going on clinically. I'm not sure the parent plays a role other than the behind the scenes, but that's not insignificant. The parent often has the ability to ask of an attorney, can you help me find a program, rather than my kid going to jail. So I think the parent plays a vital role, but I don't know if that plays into the technical part of the court proceedings itself. But that's my sense of what I've seen. That's not my technical answer as an attorney. Let's see what else we have. What liability does an outpatient clinician carry when a patient is refusing to accept? Yeah, that's a very good question. In general, I think our field is way too fearful about risk. Not that there isn't risk, but I think we should be consulting a lot more and then doing something with that consultation other than just saying we're not involved. But this is a factor. So a lot of clinicians will say to a patient, you belong in residential. I cannot and will not work with you if you don't go to residential. I'm giving you 4 weeks to get on board with that. If not, we're done. I don't like that approach for a variety of reasons, although I don't judge anybody that takes that approach. I think in concept, if you're working your hardest to get a patient to a higher level of care and you personally are willing to keep working with them to get them to that place, as long as you're documenting really well that this is what you're trying to do, I don't see how somebody could hold you responsible for the fact that they didn't actually go. I don't think the solution is to say, I'm done working with you. But again, that's the technical answer to that is ask your risk management attorney. But I think that's typically the approach I would take. I will work really hard to get you there. As long as that takes, I will document what I need. I also build in a lot of supports. I'm not typically doing this myself. I will loop in the psychiatrist, I will loop in the family. So I will work with more supports. I have time for one more question, and then again, people are feel free to follow up with me elsewhere offline. Yeah, so clients who are unwilling to participate in recommended higher level of care when the therapist believed it's needed, but the client only wants to attend counseling. Yeah, so that's a little bit of an overlap with the previous question. I think let's generically call it motivational interviewing, but you're really going to be trying to work with your client to work through the issues as to why they don't want that higher level of care. Many of those issues are perfectly solvable, but they require some creativity and thought and work, maybe money. So it's really important to get there into the weeds with them, and be able to figure out what is it that they are needing to be able to make this work. Again, you may not have the time or effort, and that is where, if you're their therapist, people bring in interventionists and ed consultants. Like, you're specializing in this, you know 100 more solutions than I do, and please help me figure out what more there is to do with that. I have to go at this point. I really appreciate having the opportunity to be here with you all. Like I said, Google me, you'll find my name somewhere, my contact. I'd love to continue this conversation elsewhere. Thank you again to TPN and Sandstone.